This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you, Ben. So when I was asked to actually address this topic, one part of me thought, metrics, okay, this is a pretty dry, boring topic. But in fact, it's indeed what we're really, really interested in, and it's something we ask all the time. How do we know we're making a difference? And it can be quite challenging to work this out. So the approach I've taken is really to look at the measures and share some of the literature and some of my thoughts about what we should be measuring, and take it from a quality improvement approach and think about the measures as outcome measures, the measures that we're really interested in, the measures in terms of what actually happens to our patients. Some of the many process measures, which is what we often are measuring, and they're perhaps easier to measure, but these are also important measures to sort of help make sure the system's working as well as it was planned or intended. And then something that they refer to in the quality improvement literature is balancing measures, and thinking about making sure that if we're implementing some sort of system, but what's the sort of effect in another part of the hospital system in terms of perhaps resources, and we've been hearing a lot about that. So I've got to also briefly speak about that. Now, I don't expect you to read any of this, but I wanted to just highlight that currently ILCOR, the International Liaison Committee on Resuscitation, are preparing their evidence recommendations for 2015. I think they come out in October. And they have a number of consensus developments conferences. The evidence, the worksheets, there's a number of worksheets for paediatric resuscitation, including one on the impact and implementation of METs or rapid response teams. So these worksheets and the preliminary data are all available on the website for us to look at, and the current draft recommendations. So I've just put this up here to highlight that this work's being done, but I really just wanted to highlight, and Kevin's alluded to this before, one of the problems with us in paediatrics is, well, I guess we haven't got that many studies. They certainly talk about the low quality of the evidence, because in fact all of these studies are before and after studies. There's no randomised controlled trial yet, or multi-centre randomised controlled trial for paediatric MET and rapid response teams. But there's a number of different outcomes that we look at, and we've all sort of done something a bit different. So I think we do need to sort of work out what is the standard outcome that we should be measuring. One of the difficulties in trying to show if MET systems or rapid response teams make a difference to cardiac arrest and mortality is the fact is that these events are actually very rare. So cardiac arrest is actually not a very commonly occurring event, especially compared to adult cardiac arrest. So it's actually very hard to show a difference in cardiac arrest. So cardiac arrest, it might be cardiac arrest for outside ICU settings that we're interested in. Mortality, what people have measured is mostly these three different types of mortality. Overall hospital mortality, so certainly much easier to measure. It's certainly objective, it's independent, and it's perhaps more easily measured. Some have tried to differentiate that the mortality that couldn't be prevented by a MET team, so for example unexpected deaths and those deaths that the children didn't have a DNR order. And then I think Kevin referred to one of the papers before where the actual mortality was actually of just those MET transfers to ICU. So they're only looking at the mortality of patients who have been subject to the MET system or the rapid response system who get transferred to ICU. And this is to, obviously, if many children who die in ICU may not have ever been in the ward environment or in the MET system, and this is to try and get around that. The more frequent events. It was actually really interesting because I'm sure, and there's many paediatric people in this audience, and we all say, yes, we know respiratory problems are the most common reasons for our MET calls, respiratory arrest, respiratory compromise, but actually few of us have actually measured this in the studies, and there's only 2 studies that have actually reported this, sometimes in combination with codes. Respiratory rest and compromise has been, I've put compromise, deterioration together, and being defined in a number of, in the studies, the 2 studies that have reported it. One actually defined it though just with intubation alone. Another defined it as bag mask ventilation or some sort of assisted ventilation that was needed. And I think we do need some definition like this where we have to come up with a functional definition, because I actually think in practice it is very hard to define respiratory arrest. When is it apnea? When is it, bag mask ventilation may start, but the child may not have actually arrested from a respiratory point of view. ICU admission is certainly a more frequent event and a measure that we frequently evaluate in these systems. The difficulty with ICU admission is that it's actually an outcome measure, but it's also a process measure. Often the decision to get into ICU might have something to do with the beds available, might have something to do with the decision of the consultant on it at any one time and what's going to happen. So I think it is a process measure as well as an outcome measure. So it's more frequent, but perhaps not the best outcome measure. What denominator should we be looking at? And the studies that have been reported, as Kevin also referred to, relating them to per 1,000 admissions is what we see, but some also relate it to per 1,000 discharges, and there are a slight difference in those denominators. When we're looking at patient days, then converting to patient days, a couple of the studies have actually, when they look at the 1,000 patient days, they remove the 9 non-ICU patient days. This, I guess, makes sense if we're trying to think about the rapid response system and its effect out in the ward environment, but it's perhaps a little bit more difficult to readily get that data from the hospital. What others have also tried to do is think about, well, what we're really interested in, and we know sometimes these events happen and they're not preventable, and let's look at the events that actually are preventable. And Brilli's paper, and his study was in Cincinnati Children's Hospital, and what he actually tried to do was classify all their codes into met preventable, that is, there was signs of deterioration prior to the call, not met preventable, thinking about the sudden clinical deterioration, like the development of a new seizure, for example, that wasn't anticipated, and he had another classification that I'll refer to a little bit later. In our paper, when we were evaluating our MET outcomes, we tried to look at this issue of preventability, and or I guess potentially preventable. Perhaps it's more about being predictable and then thinking about whether it's preventable. And we define it as any of the children who attained the MET calling criteria as they were then within 6 hours of the event. The other study I just want to mention here is this study that we're sort of very interested in from a paediatric point of view and waiting the results, is a study by Chris Basharam, who's from Sick Children's in Toronto, and he's actually leading a multi-centre evaluation of the implementation of the bedside pews. The bedside paediatric early warning score is perhaps one of the most validated scores, and he's at this multi-centre trials I think in about 20 plus hospitals. Now, they have just recently published their the study protocol and methods and trials, and it's really interesting to look at that in terms of all the various outcome measures that they're looking at. What their primary outcome is all-cause hospital mortality, and there's a big number of secondary outcomes, but potentially preventable criteria is something that they're looking at, and they've sort of taken the approach from the adverse events type studies, where they'll be looking at different the cardiac arrests, 2 independent reviewers. They have a rating scale of 0 to 6 and to determine whether that this event was potentially preventable. So those are the main outcomes measures that have been looked at. I just want to now talk about some other measures that has been shown to be of some relevance in paediatrics. So one type of event that we measure in our hospital, and we sort of termed it critical events, and these were other events that were associated with harm and perhaps delayed, associated with delayed recognition of deterioration. And these are the critical events that we have measured for some time and we report on in our hospital. a description of these critical events in one of our papers and showed that certainly the children who had these critical events had a much higher mortality than the other children who had a critical event, fivefold increase in hospital mortality. And in fact also the children were more likely to be post-operative. Some other interesting work I think is coming out of Children's Hospital Philadelphia, Chris Bonafide, and he talks about a metric called critical deterioration rate. And so this metric was validated in their hospital, and they define it as an ICU transfer and non-invasive ventilation, intubation or vasopressor infusion within 12 hours of transfer to the ICU. So these events may happen in the ICU up to 12 hours. They showed that it was these type of events, the critical deterioration events, were far more common than cardiac or respiratory arrest, and that had a 13-fold increased risk of death. They have since measured and evaluated the implementation of their rapid response system and showed not that they couldn't show significant decreases, but they certainly showed a trend of reversing the critical deterioration. Another metric that I think is interesting to look at as well, another surrogate type outcome measure for cardiac arrest and death, is this concept of unsafe transfers. Now, this is a paper out of Cincinnati Children's Hospital, and unsafe transfer stands for unrecognised situation awareness failure events, unsafe. So they had quite a complex intervention in looking at a number of quality improvement interventions to identify sick children earlier, various huddles, team meetings and discussions and planning of care. But their outcome measure, which they looked at, was a similar aspect of critical deterioration, and they looked at patients transferred from the floor to the ICU and was intubated or received inotropes or greater than 3 fluid boluses within 1 hour of transfer. So the previous paper talked about 12 hours, and I guess the thing about the 12 hours is it's still perhaps partly dependent on measuring the quality of care that's happening in intensive care, whereas this 1 hour is a shorter time and perhaps may be a better reflection of that. They showed that their complex intervention, they were targeting this measure of unsafe transfers, and they were able to reduce the unsafe transfers by nearly 50%. So going back to Chris Pasharam's paper where he defines all his outcome measures, the key secondary outcome measure is a significant clinical deterioration event. It's defined, there's a sort of many parameters to it, but essentially it's the provision of significant pre-specified respiratory or circulatory therapies or CPR in the 12 hours before transfer. So we're going now the other side of the event. So this is in the 12-hour period prior to transfer from the inpatient ward or death without a DNO order or in an inpatient ward. So those are all the outcome measures that I was going to speak about. Now just to mention some of the process measures, and I think many of these we've been speaking about over the course of the last 2 days. So certainly it's important that we measure how many MET calls or whatever the system's called in your hospital that happen. We've heard a lot more now about family activation MET, and some systems have incorporated this, and I think that's also important then to measure in terms of the system and the afferent system. ICU admissions, I've put them in here as I said before, because I think really these are process measures and it is important still to measure them. But also thinking about the smaller places that won't actually have an ICU, and some of the hospitals that Brad was referring to just now, and thinking about, well, what's an appropriate measure there, because they're not transferring to ICU. And we tried to do this with looking when we were evaluating our implementation of our statewide charts in Victoria, and come up with a measure that we called transfers out, and think of the children who are transferred out of the hospital to a high level of care to another tertiary hospital, and these are the transfers for critical for deterioration, not for because this is now where the surgery can be offered, etc. There's a lot of interest in time and day of call, and we've heard about diurnal variation. We've heard about the impact on resources and out of hours. The response time of the MET, or whatever the system is in place, and whatever the recommended response time is, and are we meeting those processes, those standards of arriving in time. And then there's a number of other aspects we could be evaluating in terms of staff. We've seen some sort of surveys of staff in terms of attitudes and have been able to highlight data that informs, perhaps identifies barriers in the system, or family satisfaction. I think now that we're getting family involved of activating MET or patient-activated MET, I think it's going to be important that we ask our families now about this, and I think it's actually also going to be really important that we should actually ask how they would like to do this. I know we've had a family-activated MET in our hospital for some time. We have a fancy little brochure, but when I ask most of the nurses each month at a talk, you know, how many of you know about this and are you talking to the parents, they're not doing it. And it's one of the many brochures that gets delivered, and the families get delivered with many bits of information when they arrive, and I think we should find out from them how they would like to know about this. Other process measures. The study that came out of Canberra Hospital, a paediatric study, and they were able to show improvements with the implementation of their PEWS system of documentation of vital signs, communication from nurses to medical staff, and time to medical review. The other point I just want to touch on, though, because I think we often talk about the afferent limb and all the ways we want to try and identify sick children, but I think with our MET data we should also it's important that we use this data, and it may not identify problems with recognising deterioration, but the data might actually identify other problems in this hospital system. And Briley also described this, and as I said before, he talked about MET preventable events, not preventable by MET, and then the third category was events not preventable by the MET, but preventable by some other means. And in his paper, he particularly referred to overdose of a particular drug. We similarly, in our hospital, I have been able to do this for some of our critical events over a period of a year, and look at using a systems analysis, a framework not unlike a root cause analysis, and follow up with staff and find out what was actually happening. And I'm just going to share one case, and I think I've partly chosen this case because there's a lot of interest in monitoring our patients at the moment. And this was an event that happened in our hospital, and a toddler who'd had cardiac surgery, was in the ICU for a day or so, had a brief period of heart block in ICU, and had pericardial, epicardial pacing wires in situ, but the pacing was no longer required. This is day 4 or 5 up in the cardiac ward. The patient was monitored. It was a telemetry monitor, so a central monitor, a monitor in the room, the little one in the middle of the night, wet nappy and all the rest of it. The nurse was in the room, changed the nappy. It was one of those typical toddlers who likes to do somersaults in the bed and lie on his tum. And so she changed all the leads and then carried on, and we were in the old hospital, so it was a 4-bedded room, doing observations on the other children. Now, the alarm was going for over 15 minutes. She was in the room. She thought, from what she could see, it was just leads off, and certainly the infant was doing somersaults and sort of looked a bit like that. This is the patient's rhythm strip. It's a complete heart block rate of 155. This toddler's heart rate was previously 120. So we were able to look at that, and sort of looking at that event and thinking about it from a systems point of view. Like many of the events that we see in our MET systems, there are many contributing effects. Now, as one of the nurses said, well, all 18 months olds pull their leads off, and we know that's a real issue in paediatrics. But there was this lack of recognition from the staff. There were many staff out at the central desk sort of going by, and were happy that the alarm was still going, which I sort of felt quite horrified, coming from an ICU background where you can't stand alarms for more than 5 seconds. But they knew the nurse was in there, and they could see she was in there, and they just thought, yeah, all is okay. And I think it also highlights in paediatrics that sometimes we're not that good at picking up dysrhythmias compared to our adult colleagues. This child, by the way, did have a cardiac arrest, and she had ECM in her, and she was resuscitated. It was a pericardial effusion that had prompted this dysrhythmia. She did all right. The task factors, the false alarm rate is really high. In fact, we did some work in looking at and 87% of our alarms in that ward were false, and that's no surprise either. It highlighted team factors in supervision and seeking help. Nobody actually went in and said, hey, nurse so-and-so, is all okay here? I see your alarm's going. Work environment. I think there's something there for us too. We have many of our rhythms displayed on a central monitor, and in paediatrics we could have the same rhythm strip next to an adolescent patient who does have a heart rate of 55, and it doesn't really look that different. And so we've got all these age-related changes, and it's challenging, and I think you know, there's a lot of opportunity for design of equipment and design of alarm systems. But I guess the biggest issue here was really the safety culture, and there was this complacency in the safety culture to sort of ignore the alarms. So there was a lot of work had to be done with this event, and we've since implemented a number of things as a result of this one event. Finally, I just want to mention balancing measures. We've heard a lot about the concern of taking resources out of ICU and running around the hospital and responding to sick patients all over the place. And people have talked about that it would be good to do a cost-benefit analysis. Well, Chris Bonafide in Children's Hospital Philadelphia has done this recently, and he's looked at, remember I talked about his definition of critical deterioration before, so he compared the costs of children who had the critical deterioration event and coming to ICU versus other ICU transfers to the ward without a critical deterioration event. He also costed various MEC composition and staffing models, so some were complete standalone if you had this composition of staff, some were models where you had a mix of the staff had other responsibilities within the ICU or elsewhere in the hospital. So he costed that a team with a nurse, a respiratory therapist and an ICU fellow with concurrent responsibilities, so they did have other roles, that would cost approximately $350,000 thereabouts per year in their hospital. And the cost of that would be recouped after 3.5 critical deterioration events. So he costed that each of those critical deterioration events, and they analysed their data, was about $99,000 more than the cost for other ICU transfers who didn't have a critical deterioration event. Hope that makes sense. So in summary, actually what I was wanting to think about in this talk was thinking, now wouldn't it be good if we could just come up with a minimum data set, and all of us here in Australia and New Zealand, let's all collect the same data. And I haven't been brave enough to actually come up with that yet, because I'm not sure I know the answer yet, but I think there's a lot of brains in this room that might be able to help. Certainly we still need to measure paediatric cardiac arrest and death, but recognise that they're relatively rare, but we've got to measure. In the end, that's what we really want to prevent. I think we should be looking at respiratory arrest or some definition of compromise, and that we should be all measuring that. The surrogate measures that I've described in critical deterioration, early days, I know some people will argue and say, but surrogate measures don't necessarily translate into the other bad outcomes. But I think that there's some interesting data out there, and we need to study this. There are a lot of process measures and that we can be measuring, and that's partly dependent on knowing our own hospital system and what the problems are as to what might determine we should measure. I think also we obviously need more cost-benefit analyses to try and support our case, and I think in the cost-benefit analyses there's an awful lot of data to collect, so we should factor in the actual work of collecting the data and having a system, because sometimes the data that needs to be collected is in itself quite time-consuming. So thank you.